Well, it's a real pleasure to welcome Dr. Ellie Papa-Emmanuel from Memorial Sloan Kettering Cancer Center for this year's DiMaggio lecture. Mrs. Emily Frederick DiMaggio and her late husband, Dom DiMaggio, made a substantial gift to Dana-Farber in 1978 to establish the Emily Frederick DiMaggio Lecture, an annual seminar in basic science. The late Dom DiMaggio was a 7-time All-Star and 10-year veteran of the Boston Red Sox. Mrs. Emily DiMaggio was nominated to Dana-Farber's Board of Trustees in 1977 and served on numerous Dana-Farber leadership committees. We are grateful to Mrs. DiMaggio for all she has done for Dana-Farber over the years, and we are deeply honored to host this annual seminar, which bears her name. And we are also deeply honored to welcome Dr. Ellie Papa-Emmanuel from the Memorial Sloan Kettering Cancer Center, who will speak to us on genomic discoveries in clonal hematopoiesis, in myelodysplastic syndrome, and in acute myeloid leukemia, and in translating genomic discoveries in these areas into clinical practice. Before joining the faculty at MSKCC, Dr. Papa-Emmanuel was a postdoctoral fellow with Peter Campbell at the Sanger Institute in Cambridge, UK, where she did some seminal work and is really continuing to transform the field today. Dr. Papa-Emmanuel, we look forward very much to your lecture. Thank you very much for coming virtually to Boston.
Thank you so much, Matthew, for the invitation. It's a real pleasure to join you here, even albeit virtually, and present some of the recent work and how we think about where we are in the field right now. So looking forward to the talk and the questions afterwards. Before I start, I should disclose that I do have some conflict of interest that relates in part D of my talk, and I'm going to highlight that in that time. So in my today's talk, I'm not going to go deep into the disease specializations that we're working on, but most importantly, I'm going to start with a very brief introduction and then highlight more of the approaches, the methodologies, and more some generalized insights that we've derived from population-based studies on how we proceed with biomarker definition for the development of patient-tailored clinical decision support tools. And that's going to cover the majority of my talk, but I have reserved a little part at the end, 4 or 5 slides, to discuss about how we think about the implementation of genomic profiling technologies in clinical practice in the future, and most importantly, our experience with implementing clinical cancer whole genome and transcriptome sequencing at MSKCC. So needless to say, I'm speaking at the house of many of the cancer discoveries in terms of the advances from the genomic profiling approaches and the implementation of many of the algorithmic methodologies that have supported them over the past 10 years. And we've gone from the have been very fortunate to be a small part of these exercises where we've gone from the development and deployment of cancer genome profiling technologies across multiple tumor types to the understanding of how specific gene mutations may be associated with the underlying disease etiology, and most importantly, how we derive insights with biological mechanisms and how we can then inform the development of targeted therapeutic approaches or clinical practices that are very much tailored to not just the disease subtypes that may be treated in clinical oncology, but specific to the molecular subtypes as we're increasingly appreciating them. So we're now at a stage where we have a very deep understanding of the catalog of gene mutations in cancer and the mutation processes that underlie them, thanks to the work of many colleagues around the world. We kind of over the past 10 years have developed comprehensive knowledge bases to support us in the annotation and interpretation of those mutations to inform clinical decision making. And most importantly, we see how kind of tied to that understanding there's been a parallel execution that drives translational research that has enabled a very, very rapid acceleration, as shown here, of targeted therapeutics that have now converted kind of a distribution of molecular markers to biomarkers of treatment decisions. And shown here is how, in the past 5 years alone, we've seen a significant increase in the characterization and the deployment of FDA-approved therapies that are molecularly informed. So in parallel with all of those advances in clinical centers around the world, as well as such as DFCI, there's been increasing implementation of prospective clinical sequencing at the time of patient presentation. And that is both to understand what is the molecular profile of each patient's tumor. And the process, the end product of this process is the delivery of a report for which what we appreciate as the most relevant characteristics of that tumor are being summarized in order to inform diagnosis and treatment decisions. And it is at that stage, and it is at this precise intersection of data and the implementation of delivery of an understanding of how that information can be translated into clinical decision-making, where over the past decade, we have developed a very strong interest. And in particular, we're exploring population genomic studies and the statistical power that comes in the numbers of characterizing well-annotated clinical cohorts with regards to disease presentation, treatment, and outcomes, and combine that with molecular information and statistical modeling approaches in order to understand both how these mutations may be relevant in cancer biology, but most importantly, how we can utilize and improve clinical care for cancer patients and support the clinical oncologist in that process. So we're learning, we appreciate that the cancer genome as a whole is quite heterogeneous. It's comprised not just by the most frequently mutated genes, but also a long tail of rare genes, that most patients have a genetically and clonally heterogeneous landscape. And to address that, in the lab, we're leading a number of international working group efforts, particularly in hematological diseases such as MDS and AML. And some of the insights that I'm going to present today are coming from those studies. And very much the product of this effort is to provide the necessary evidence and validation for the incorporation of molecular biomarkers into clinical decision support systems for classification and risk stratification. And one thing that is always kind of at the front of our mind is that at the end of that clinical report, there's always a single patient, and that the ways that we are looking and interpreting our data is with that single patient in mind, and also in ways that extend beyond the deployment of a targeted therapy, but thinking precision medicine as a more holistic journey, starting, if possible, before the time of diagnosis in the identification of who may be at risk, and going all the way to guiding optimized therapies, as well as predicting further clinical endpoints such as relapse, progression, and long-term sequelae that may come in our survival populations. So with that introduction, I'd like to take the first dive on how we think things at the very simple first layer. And that is kind of our statistical models are always as good as the features that we embed into those models. So of course, at the very starting point is how we define gene mutations. And in the clinical setting, or the molecular markers that we may be considering at each time point. And in the clinical setting, The most widely used and practical approaches consider the implementation of panel-based sequencing. This is a workflow rendered by the MSK impact workflow, where it was chosen to perform matched tumor normal sequencing as a means to both identify germline mutations, but most importantly, subtract artifacts through sequencing the normal sample. But of course, there are many, many platforms that have opted to perform unmatched sequencing data and annotate and report high confidence mutations. And of course, now there are data sets that are large enough that can develop pretty confident heuristics on how we annotate and report the most relevant mutations. So I've recently worked with Ahmed Zahir, who is leading the clinical bioinformatics department at MSK-CC, and we evaluated the first 100,000 or so mutations that were reported through MSK Impact, and the distribution of those, of how they may have been annotated as oncogenic and embedded into a clinical report, or non-oncogenic, shown here in dark blue. And what we realize and see here is that the majority of the mutations that we map in a very well-defined panel of 485 cancer genes are single events. So more, or almost 90,000 of the mutations that were identified and characterized were single occurrences in a cohort of approximately 10,000 patients. A smaller proportion included highly recurrent mutations, and our ability to mark mutations as oncogenic, of course, increased with the level of recurrence of those mutations. But it was clear that most of the findings included single occurrences, and in that setting, in a background of a denominator of more than 10,000 individuals, most of those mutations could not be confidently assigned for their putative role in cancer pathogenesis, and most importantly, informing clinical care. And kind of heuristic approaches that rely on specific criteria like hotspots or functions or clinical domains can work very well for certain genes that have clearly demarcated hotspots or functional domains. However, there are other genes that can be far more heterogeneous in the nature of the molecular presentation across the gene body. So we asked the question as to what the impact may be of selective reporting of such mutations. And what we did is we took the criteria that have been adapted by the American Pathology Association, Molecular Pathology Association, and implemented through a large number of hotspot annotation processes of unmatched or matched sequencing data. And we applied it in a data set of almost 10,000 myeloid neoplants we had generated in-house, of which we had manually annotated 25,463 mutations, and have annotated them as oncogenic or likely oncogenic, or mutations of unknown significance, but with more relaxed criteria than kind of those strict hotspot or functional definitions. So for every gene, we characterized which of those mutations would, by the clinical criteria, be reported or unreported. And we see that for the most frequent gene mutations, a very large proportion of those mutations would have been reported, but still about 1/5 or 1/4 of those mutations in certain genes would have not reached the criteria for clinical reporting. On the other hand, when we go at the most rare genes, we see that the majority of those mutations, with the exception of the hotspot mutations, would actually not make it into a clinical report. So we then used the matched clinical presentation and outcome data, and here I'm only going to show a summary of the outcome data, to ask whether there were any differences in the projected outcomes between the high confidence mutations that reached the criteria for clinical reporting compared to the ones that we had manually curated as likely oncogenic or oncogenic that did not fit that criteria. And we noted that for the vast proportion of genes that we looked, that those mutations in those rare genes actually had similar associations with clinical presentation, not shown here, and most importantly, outcome. So when guidelines like that are being defined, we usually think about the most common scenarios. And what we realized in this exercise was that up to 30% of what appeared to be clinically relevant mutations would have not been reported clinically because they were too rare or the lack of prior evidence on the basis of recurrent hotspot mutations or function. And this highlights the impact that the level of annotation that may have when a patient that may have, when it comes to reporting these mutations for a single patient that may be a carrier for one of those mutations rather than the cohort as a whole, and the opportunity that we have as a community in merging these data sets and developing further classifiers that can help us to continually improve our annotation processes. Another consideration when mutations are being reported is that the majority of those mutations are reported as mutated or as wild type. And for example, the most frequently mutated gene in cancer, and most likely one of the genes that we understand the most across cancer indications, is TP53. We know that P53 presents with a distribution where most mutations fall within the DNA binding domain. There are different hotspot mutations across different cancer types. And whilst we know that the biallelic targeting of P53 is frequent, either by mutations or allelic imbalances, these are not always obligatory events. And in fact, we know that across tumor types, P53 is frequently also associated with single hit mutations. And there has been a wealth of data that explains this presentation, particularly with the characterization of dominant negative effects associated with specific P53 mutations or gain of function events that would not necessitate a biallelic targeting of this gene. And this is important because P53 mutations in most tumor types have been associated with pretty adverse outcomes. And this is indeed the case in myeloid neoplasms, where carriers of P53 mutations have been shown to not respond in what is considered standard of care, such as hematopoietic stem cell transplantation, or, for example, lenalidomide in MDS. So, and it is generally appreciated that P53 mutations are associated with very adverse risk, chemoresistant disease, and poor response to alternative therapeutic agents. So in one of our recent studies in myelodysplastic syndromes, we're working with the MDS Foundation and the International Working Group to develop the new classification and risk stratification criteria for MDS. And kind of our first approach is to always look each gene at a time in order to understand how best to characterize gene mutations and embed them into our downstream prognostic models. So in our first cohort of 3,324 patients, we identified 11% of patients with MDS, which is consistent with prior literature, to carry P53 mutations. And in fact, we characterized 486 mutations in 378 patients. So this already highlights that certain patients had at least 2 mutations in P53. And coupled to mutation profiling, we also applied copy number analysis of panel sequencing data. This is a panel that was specifically tailored to genes that are currently mutated in myeloid disease. And we also mapped focal deletions, arm level deletions, and regions of copy neutral LOH across the genome. And 17p is frequently targeted either by arm or chromosome level deletions, as well as focal events targeting the P53 locus, and most importantly, copy neutral LOH. And what we noted when we integrated gene mutations and allelic imbalances in our data was that for those patients that had 2 gene mutations in P53, we very infrequently found allelic imbalances overlapping in that locus. However, more or at almost half of the patients that had 1 mutation in P53, the second allele was targeted by either copy-neutral LOH or deletion. But there were also about half of patients with a single p53 mutation that did not have any evidence of targeting of the wild-type allele. So in our cohort, the distribution looked as such, whereas 2/3 of the p53 patients had both alleles targeted by either two mutations, mutations in CNLOH or mutation in deletion, whereas 1/3 p53 patients had a single mutation. So we asked whether there were any differences in the molecular, clinical presentation and outcomes for those patients. There was no difference in the distribution of the mutations in terms of hotspot mutations or across the DNA binding domain. And when we looked at clinical presentation, we noted that patients that had 2 hits in p53, shown here in the blue bar, were generally more cytopenic and had increased blast counts, which in MDS is a marker of disease severity. Whereas patients that had a single hit in p53 did not differ from wild-type patients when it came to clinical presentation with regards to peripheral blood counts and bone marrow morphology. But what was most striking was that when we evaluated clinical outcomes and compared patients with a single mutation in p53 with patients that had 2 hits, we noted that patients with a single mutation did not differ from wild-type patients, where patients with 2 hits were associated with a highly adverse disease, consistent with what we had previously appreciated in more broader correlative studies. And the same was true when it came to disease progression, measured here as a cumulative incidence of progression to AML, but as well as in the context of treatment response, where when we segregated patients with a single mutations and 2 mutations and evaluated how they may respond to lenalidomide, HMAs, as well as transplants, not shown here, we noted that actually patients with 1 mutation could benefit from those treatments. And really it was the patients with 2 mutations that did not benefit from these therapeutic options. And this is important because currently our arsenal of treatments in these diseases is not very broad. And kind of without the differentiation of allelic state in p53, many of those patients may have not been considered eligible for these therapeutic approaches on the basis of the presence of a p53 mutation alone. And here we show that by consideration of allelic status, it is now possible to identify 1/3 of those patients who may benefit from those therapeutic options, and really also characterize those truly high-risk patients. We also tested this in multivariate analysis across all standard risk factors, as well as all gene mutations. And here it's shown that both for overall survival in left, as well as AML transformation in right, monoallelic p53 mutations are truly not significant. And the adverse prognostic indicator is very specific to p53 multi-hit cases. So this also highlights that as we move on to develop more detailed and molecularly integrated models, the need to really differentiate on how we encode biomarkers on the basis of allelic state. We also these type of approaches also help us derive some biological insights in that when we looked at the clonal representation by means of VAF estimates shown, uncorrected VAF estimates shown here, we noted that cases with 2 mutations or mutations and loss of the wild-type allele tend to be more clonal, whereas cases with 1 mutation tend to be subclonal. And in fact, cases with 2 mutations, most frequently shown here on the right, associated with profound genomic instability, whereas cases with 1 mutation really had a paucity, with the exception of very few cases, had a paucity of genomic instability. And on the contrary, cases with 1 mutation often commutated with many, many other class-defining or disease-defining genes in myeloid disease and were subclonal to those mutations as compared to cases with multiple mutations. So this shows that likely the early acquisition of a p53 mutation confers a selective pressure for a second hit, and that can be mediated by either mutations or chromosomal aneuploidies. Whereas kind of a late TP53 mutation is most often presented as a single hit, and it comes in the context of prior disease mutations. And in the absence of a selective pressure for a second hit, there is no profound genomic instability and no associations with a p53-like phenotype. So kind of to summarize the first part, we're now in a position kind of as a community where real-time mapping, reporting, and clinical utilization of genomic data to inform clinical care is now a reality. However, there is still kind of, this is not a done deal. And as we increase our population sizes and our annotations, there's a real opportunity to refine how we define biomarkers, and most importantly, how we incorporate them, how we map them, incorporate them, and report them into guidelines for diagnosis and further treatment decisions. And that is really important because we frequently rely on prior annotations of molecular data to develop clinical decision support tools, as well as implement correlative studies of response. And there's often can be hidden signals that we may be missing unless we go back and look specifically into how we define and select for features, even for genes that we think that we know very well, such as p53. So in the second part of the talk, I'd like to move on how we start layering on this type of information to develop or prototype the development of more integrated clinical decision support tools for both early diagnoses and risk stratification in the context of clonal hematopoiesis, as well as to improving diagnosis and treatment decisions in the context of acute myeloid leukemia. So we know that the mutations that define each tumor determine both the tumor biology, but the likelihood of disease progression, as well as the response to external pressures such as therapy. And that this overall process from the early first clonal expansion all the way to the development of overt malignancy is a multifactorial problem. And it's almost never underlined by a single gene mutation. There's often the necessity to target multiple gene members that act in concert to deregulate biological function and confer cell fitness, but most importantly, also cell intrinsic and extrinsic effects. So kind of in the first part of the talk, I've mentioned about early p53 mutations and how we learned a little bit about its trajectory from studying patients at the time of diagnosis in MDS. And at MSK-ACC, we've leveraged the MSK Impact cohort initially in a study of 24,000 patients, of which 11,000 had detailed treatment information. And the fact that we use a matched tumor normal assay has enabled us to develop bioinformatic workflows that can detect in real time clonal hematopoiesis in the blood of our cancer patients as they present to the clinic. And through this process, in a study published last year by Kelly Bolton and members of the lab, we showed that 1 in 3 cancer patients has clonal hematopoiesis. And the ability to register those patients in real time also enabled us to kick off a prospective sequential sampling study over the past 4 years, where we enrolled 500 patients and obtained sequential samples during their treatment course. Focusing specifically for a significant proportion of those patients, we extracted information on treatment data, as well as outcome data, such as the development of subsequent myeloid leukemias. And through a meta-analysis with some other published cohorts in cancer population, we were also able to use those informations to define predictors of TMN progression. And it has been shown by many members of your institution that CAH is frequent in the population and it's associated with an increased risk of myeloid disease. And the same is true in the setting of cancer patients. And in fact, similar risk factors prevail in both population cohorts, where more than one mutations in clone size, as estimated by VAF estimates, is increasingly associated with the odds of developing myeloid neoplasia. And amongst the genes that were most frequently mutated in the CAH of our cancer patients, we also noted that P53 was the strongest predictor of disease progression. In a retrospective cohort, we also noted that patients who had CAH defined by TP53 mutations were enriched in individuals that had received prior cancer therapy prior to sequencing, prior to impact sequencing. And we noted that there was a significant enrichment indeed of CAH with mutations in multiple components of DNA damage response pathways, such as PPM1D and CHEK2, in addition to P53. So in a retrospective cohort, we noted an association of the presence of prior treatment and an enrichment of CAH with mutations in DNA damage response genes, such as P53. And then we asked the same question, whether there was a causal association in our prospective series, where we resequenced samples from patients that had CAH mutations. And for every patient, we knew if they had received therapy or not in between the two sampling intervals. And we were in position to ask whether clones with P53 mutations or mutations in DNA damage response genes showed clonal expansions when in the presence of treatment, as compared to clones that harbored mutations in other myeloid genes. And some of the results are summarized here, where we show that in sequential sampling, the growth rate of clones that had mutations in DNA damage response genes was higher when there was treatment in between the two sampling intervals, as compared to cases that had CH clones in the same mutations in the absence of therapy. So what this suggests is that those clones with mutations in P53 or other DNA damage response genes are at an increased fitness when exposed to genotoxic therapy, such as platinum agents and topoisomerase inhibitors, but not so much in the absence of those exposures. So this suggests an alternative model for the development of therapy-related leukemia, whereas rather than the historical anticipation where genotoxic therapy directly causes mutations, here an alternative model, which is not unique to our data, but it's further corroborated by our data, where those clones which are pre-existing therapy are then preferentially selected whilst on therapy and undergo further genetic and clonal evolution and result in TMN. So this is important because as our arsenal of therapeutics across solid cancers is improving and increasing, so is our cancer survivorship rate. And in fact, in the course of this decade, it is expected that our cancer survivors are going to increase by greater than 5 million. And one of the long-term consequences of cancer therapy can be the development of therapy-related leukemia, which represents one of the chemo-resistant and lethal cancers. So our ability to identify risk factors that prevent the development of therapy-related leukemia can help us not only detect early those individuals, but potentially inform strategies that may prevent the development of this disease. And so, imagine now the context where a cancer patient presents into a clinic and they may have low risk disease of breast cancer, and they can the standard treatment plan may include surgical resection. However, a potential of adjuvant chemotherapy may be considered as a good measure to prevent relapse, and how that decision may alter if we know that that cancer patient may also have clonal hematopoiesis defined by mutations in DNA damage response pathway. From the one hand, we may be considering cancer therapy for the prevention of a cancer, that we now have toolkits to measure early relapse and that are potentially quite treatable, such as low-risk breast cancer. On the other hand, we want to evaluate this against the risk of having a p53 mutated clone in the blood and its potential to accelerate to aggressive and chemo-resistant therapy-related leukemia. So we try to model whether by integrating this type of data sets, we can inform the development of risk-adapted treatment decisions. So we used epidemiological data for TMN transformation that have already delivered estimates of the effects of the incidence of therapy-related leukemia in the context of breast cancer patients, the risk effects associated with cancer therapy, and we've incorporated contributions from CH parameters as learned from our cohort. And by doing so, we could deliver a prototype model whereby we could use all those features to estimate the proportion of patients that may be at a high risk of developing subsequent therapy-related leukemia. And indeed, that was quite low. So focusing on the top 1% of the individuals at risk, then we were in a position to model a question as to what is the risk of TMN in patients that may have clonal hematopoiesis, and how that risk may be shaped if we administer adjuvant therapy now, as opposed to defer adjuvant therapy now for their primary kind of breast cancer treatment. And this model showed, shown here on the top, that if we were to defer cytotoxic chemotherapy, we could, for the top 1% of individuals at risk of TMN, we could decrease the risk of developing therapy-related leukemia by almost 10 percentage points without altering their likelihood of overall survival from the primary cancer. So this is, of course, a prototype model. Prospective studies will be needed to further substantiate and validate this type of approaches, but it very much highlights the need to integrate factors on both kind of the molecular presentation of the disease as well as other exposures that may be contributing to disease presentation, such as here therapy and potential interaction effects that may exist between the two in future studies. And kind of beyond mutations, I think our field is pretty mature in the study of clonal hematopoiesis when it comes to gene mutations, because the type of tools that we implement, such as panel sequencing or exome sequencing, are well positioned to map gene mutations. However, we do know that at the time of disease transformation, p53-related leukemias are very often accompanied by chromosomal aneuploidies. So I was very fortunate to work with Teng Gao, who was a former member in the lab, and it's now a PhD candidate at Harvard. So I would definitely recommend you look out for him. And kind of inspired by our p53 story, and also the data that we saw at CH, we asked the question whether we could implement a process whereby we can detect subclonal copy number alterations from panel sequencing in a way to map allelic imbalances or mosaic chromosomal alterations associated with CH from the MSK impact cohort, in addition to mapping gene mutations. So I'm not going to go into detail of that data, but in this study, which has recently been published, we showed that we were able to recapitulate the distribution and spectrum of allelic imbalances previously reported by SNP arrays without haplotyping phasing from panel sequencing data. And by integration of allelic imbalances and gene mutations, we were able to map and identify cases that harbored both gene mutations and allelic imbalances in the same loci. And we show this in the context of p53, where we can identify allelic imbalances targeting the 17p locus in individuals with p53 clones as small as 4%. And kind of this is important because in this cohort, we then asked whether mapping allelic imbalances can further inform or refine individuals that may be at risk of developing therapy-related leukemia. So we identified individuals that had progressed to TMN at least 3 months out of the time of impact. And we asked whether the capturing of allelic imbalances in addition to gene mutations represents an independent risk factor. And here we show that individuals with mosaic chromosomal alterations and gene mutations in CH, so that is in a pre-leukemic, pre-malignant state, had a 14% incidence of cumulative incidence of TMN within 3 years, whereas individuals with just gene mutations or MCAs only had less than 1%. So this further highlights that as we're developing algorithms to map CH to identify individuals at risk for myeloid disease, it is important to not just consider gene mutations, but also mosaic chromosomal alterations. And we're now trying to understand the dynamics of the emergence of those allelic imbalances by incorporation of single cell whole genome sequencing approaches. And last week, we got our first 500 whole genome sequencing data shown here from a single cell, and we're digging through that data right now. So the first example was on how we can use this type of approaches for early detection and treatment and risk stratification. And I would also like to present some data on how we incorporate the type of data that one can derive from through prospective clinical sequencing to further refine diagnosis and treatment decisions. So, and this is important because kind of we are getting a very good understanding of how individual gene mutations behave. But kind of when we look at a cohort as a whole or at individual patients, we know that every type of leukemia or cancer is not just defined by a single mutation, but a combination of gene mutations. And to exemplify this point on how profound this heterogeneity is, even in acute myeloid leukemia, which is an exquisitely simple disease or cancer, we sequenced 2,113 patients across our myeloid panel, and we identified 1,653 unique genotypes. So this highlights the problem of how the treating physician might need to consider those unique genotypes and the difficulty in being able to readily translate and impute within one's head that information into clinical decisions. And in AML, kind of whilst targeted therapies are slowly emerging, the backbone of therapy is that as soon as a patient is being diagnosed, they will receive induction chemotherapy. High-risk patients will be considered for an extra layer of consolidation chemotherapy. And at the end of each round of therapy, a patient might die or might enter remission or might have residual disease, which is considered an adverse risk factor for relapse. And one of the most critical decisions, and probably the only curative treatment for AML, is the delivery of hematopoietic stem cells transplantation. And the question there and the clinical dilemma is whether to give a patient hematopoietic stem cell transplantation at first remission. However, stem cell transplantation is associated with significant mortality, or whether to wait for a patient to relapse and potentially give this as an exhaustive late-stage therapeutic option. So conventionally, diagnosis and treatment decisions are informed by classifying patients into meaningful groups that we understand better in order to derive treatment decisions. In the context of AML, the current WHO classification can classify just 50% of patients, and this is primarily relying on cytogenetic markers. And the risk stratification uses cytogenetic and some gene mutations to assign patients into favorable or adverse risk groups, and everyone else falls in between. So we kind of use more advanced statistical modeling approaches to incorporate mutations and define molecular components or classes. In a recent study, we were able to identify 14 molecular subgroups just by the use of 32 class-defining genes and cytogenetic markers that explained 100% of the patients. And each one of those groups speaks to a distinct evolutionary path. We note recurrent patterns of commutation and really very much speak to a diverse etiology that results into an AML-like phenotype. So we use these approaches to first define those molecular subgroups, and then informed by the likely clinical course of a patient, usually in prediction exercises, we look at overall survival or event-free survival or relapse-free survival as endpoints. So one approach we took is we tried to model each stage in the clinical course of every patient, going from being alive to receiving therapy, to receiving complete remission, to relapse, and tried to develop multi-stage predictions for each course of the clinical journey. And we did this at a gene level, but we also did this at a class level. And what we observed was that we could resolve the heterogeneity in clinical outcomes when we started to implement these biological groups that we've learned from our classification exercises, to the point where we could identify molecular subgroups that may have similar overall survival, but when we compared the two, certain groups had a much higher incidence of death without CR, whereas other groups had much higher proportion of death of individuals who died at relapse. So this shows how we can take now prospective sequencing data at the time of diagnosis and implement supervised classification approaches to assign patients into distinct molecular classes. And learning through population-based exercises, we can not only anticipate that an individual may be in a group that's high risk or low risk, but we can use data-derived estimates of the likely trajectory of each patient. And by doing so, we can also ask questions about how to optimally inform therapeutic choices and the timing of those choices. So kind of here we show that we can also reduce the type of signal to the most relevant signals that can inform classification. And kind of in our population-based studies, we showed that using class-based modeling to predict clinical outcomes and multi-stage predictions, we can reach significant improvement in our risk estimation than standard of care, and also derive biologically and clinically meaningful disease entities. And of course, we recognize that this cannot be readily interpreted within the setting of clinical care. So our lab invests a lot of time to deliver web-based clinical decision support tools that consider clinical, demographic, and molecular variables, and then output dynamic in time predictions for a patient's likelihood of outcome likelihoods across each time point. So I'm reaching to the very end of my talk, so I'm going to try and take a maximum of 4 minutes. In the first 2 parts of the talk, I kind of showed how we're trying to deploy our population approaches in the interpretation and implementation of molecular profiling technologies as derived by panel sequencing. And I wanted to kind of give you a very high-level summary of where we are by expanding those efforts from panel to whole genome and transcriptome sequencing. So currently at the time of diagnosis, there is a vast array of different molecular assays that are being deployed in diagnostics in order to capture the most informative biomarkers to inform clinical care. And we know that across tumor types, whilst panel-based and targeted approaches can be highly effective in the very frequent and common cancer types, as soon as we go into the more rare disease indications, such as pediatric cancer, but not exclusive, the vast majority of patients do not benefit from this type of approaches. And if we were to have a circus plot view of clinical panel sequencing, this is the characterization of how a Pencer genome might look. And this shows a patient that reported in the pediatrics department at MSK, where panel sequencing identified 3 mutations of unknown significance. And the level of information and data we were able to extract for the exact same genome when we deployed whole genome sequencing approaches. And this highlights both the opportunity in terms of the richness of the data that one can derive, but also the challenge on which of those 13,000 mutations may inform diagnosis or clinical care for that patient. And in fact, our community is slowly appreciating the relevance, and whilst it's well conversed in implementing whole genome sequencing in the research setting, I think we're still quite early in our understanding of how we can use whole genome sequencing within the clinical setting. We appreciate that the integration of whole genome and RNA sequencing can capture the array of biomarkers that may be captured through multiple diagnostic assays, and offers the opportunity to test in a single assay 100% of all the relevant biomarkers. However, the main challenges are: how can one turn around the vast analysis of data associated with whole genome and transcriptome sequencing within clinically relevant timeframes? There is real concern in the sensitivity of whole genome sequencing data to detect actionable mutations reported by high-depth panel sequencing assays, and the interpretability of findings. So at Sloan Kettering, I'm also part of the Department of Pediatrics, and we were cognizant about on how many patients came through our doors that did not benefit from panel sequencing. So we first implemented a platform that's available to academic labs that would help us to scale and automate complex analytical workflows, such as whole genome sequencing analytics. And we've developed an end-to-end workflow from surgical biopsy to a clinical report for a molecular tumor board that's executed within 12 days. So that's biopsy, DNA extraction, sequencing, analysis, and report and discussion within the tumor board. We tested whether whole genome sequencing could capture the mutations reported by MSK impact. And we found that once accounted for intratumor heterogeneity, 98.5% of the mutations reported by MSK impact could be recapitulated by whole genome sequencing. And then we last asked whether whole genome sequencing could further derive, as we understand them today, biomarkers of clinical relevance. And we noted that we were able to identify molecular findings that could inform clinical care in more than 50% of the patients in our cohort, and that whole exome sequencing and RNA sequencing approaches alone would capture less than 15% of those added findings. And the reason for that is that when we looked specifically to the added findings, the majority of those events were characterized by structural variants, genome-wide mutation signatures, or fusion genes, which can be also characteristic to the population that we studied, which was enriched for pediatric cancers and rare adults. So as a finishing slide, when compared with panel sequencing approaches, which were able to identify a clinically relevant biomarker in 42% of patients, we showed in a pilot of 114 patients that 99% of the patients could have their genomes explained, with actually 65% of them, and now 75% more clinically relevant findings. So we're paying close look on how we describe biomarkers from the simple assays, but we're also looking into the future on how we can expand the portfolio of those assays and the implementation of our analytical approaches into whole genome and whole transcriptome in order to optimize decisions and inform the entire journey of a cancer patient. So with that, I appreciate I covered a lot. So I would like to thank everyone who contributed to this effort, and especially Andrew Kang, the chair of the pediatrics, who had the vision to implement this program at MSK. And I acknowledged everyone else along the way, and you for your attention. So thank you so much.
Wow, thank you, Ellie, for a really spectacular presentation. So I just want to open this up to questions from the panelists and and everyone in the audience. So if you have a question, please type it into the Q&A, and then I'll read it out with who's asking the question and what your question is. So everyone, please go ahead. But meanwhile, I'll start. I actually think I want to start with something early in your talk with P53 mutations. And then if I have a chance, I'll ask a question from the end as well. So it was really striking that you saw that basically cases with a single allele P53 mutation looked a lot like wild type tumors. And those with biallelic P53 alterations looked very different. How do you think this relates to the idea that P53 mutations are dominant negative versus the idea that they're pure loss of function? Love to hear your thoughts about that.
Yeah, that's a great question. So, and I should also say that we also looked specifically for those hotspot mutations to see if the same signal was observed in the setting of a single mutation or two mutations. And with the exception of one hotspot that's associated with gain of function, we still saw the difference in one versus two mutation. So many of those descriptions of dominant negative and gain of function events have been also described in the setting of exposure to therapy or different settings than what we would see in a treatment-naive myelodysplastic syndrome. So it could be that some of those attributes might come as response to an environmental exposure, but not in a steady state condition. And that is kind of reminiscent of what we've seen with clonal hematopoiesis, where we don't see a big selective fitness in the absence of therapy, but in the presence of therapy, then those mutations may be associated with a more increased fitness.
Oh, that's a really interesting thought. Thank you. I'm now going to turn to a question from the Q&A function. This is from Serena Avagian. And Serena says, great talk. How do you think about using the many more subdivisions of AML, or any other disease for that matter, in the context of designing trials for improving therapy for some? We lose so much power by bitting the patients in smaller and smaller groups. Thank you. So it's kind of the statistical power balance.
Yeah, we can flip this in two ways, right? We can think about smaller groups, but we can think about biologically defined entities. And appreciating that there's a direct link with the mutations that cause that leukemia, its presentation and treatment response, we may actually be better powered by contextualizing our correlative studies in that regard than by doing it using single mutations that may transverse molecular groups, where the context of those effects might change depending on the commutators. So I would probably argue that having a more refined definition and a biologically driven and rationalized definition of our correlative groups would empower us to detect signals that we might miss if we try and merge heterogeneous populations in one group.
Yeah, maybe I shouldn't comment, but I'm very much a believer in this view as well, right? That you need to get to that biological population. Here's another question from Jen Karajan, who says, great talk. How do you see the benefit of WGS coupled with RNA sequencing for improved structural variant and gene fusion detection in the clinic?
So I should highlight that I'm a real believer in that, and that also associates with the conflict that I have, that I mentioned earlier, in that I'm an absolute believer that whole genome and transcriptome sequencing can help us identify and validate and interpret the role of structural variants in cancer. And in fact, in our clinical experience at MSK, it helped us resolve diagnoses, identify prognostic markers, as well as therapeutic targets that would have not been otherwise identified in the absence of whole genome and RNA. And the integration of the two gives confidence in the interpretation of the findings, in that you have two orthogonal assays that you can detect the same event. But also, if we look beyond fusion genes and start thinking about enhancer hijacking events and so on, then we can start correlating structural variants with gene expression to add confidence in the annotation of those biomarkers. And the Illumina announced the $600 genome in February, which is cheaper than panel testing. So I wouldn't be surprised if this is around the corner.
So I'm going to ask another question about whole genome sequencing. Yesterday, I heard a talk by Evan Eichler, who was talking about assembly of whole human and primate genomes using a mixture of short read and long read sequencing technologies, and talking about the degree of structural variance that you can observe with long read technologies. What do you think about the application of these technologies for?
Yeah, so I don't have firsthand experience, but 2 weeks ago, I invited Marcin Mielinski to give a talk at MSKCC, who's your trainee. And he was looking exactly into that question, the ability of short reads versus long reads. And whilst he demonstrated really elegant examples of where long reads can help resolve the context of complex structural variants, his interpretation and from his data, and I'll defer to him to correct me, was that for the vast majority of SVs, we are powered to detect them using our short read sequencing approaches. And that was not what I expected. And it was actually quite gratifying to see from his analysis. And it's really interesting data.
Wow, fascinating. All right, thank you very much for a really wonderful talk and wonderful discussion. We are now at 5:05 p.m., so we are at the end of the question time. So thank you for making this virtual visit to Boston from what looks like your greenhouse. And,
thank you for the invitation. Yes, I really appreciate it. It's great to be part of your community.
And we hope to host you here in person one day.
Take care. Thank you.
All right, bye-bye.
Bye-bye.